Hey, DNA. Kate Wilson here with another episode of All Access DNA. I am begging you to fill out our listener survey. This helps us find out about what you like, what you don't like, and what you want to hear more of. So find the link in our show notes. Today we are talking to Beth Sheidley, she, her, about epilepsy and genetics. She discusses what epilepsy is, its causes, and the role of genetics in diagnosis and treatment. Let's get started. Hi, Beth. Thank you so much for being on the show today.
Hi, Kate. Thank you so much for having me.
I wanted to talk to you about epilepsy, and I feel like it's common enough that people have probably heard of epilepsy or at least heard of seizures. But if somebody's that's unfamiliar about it, what is epilepsy? What does that term mean?
Yeah, no, it's a commonly asked question, actually. So, epilepsy is diagnosed when an individual has had two or more unprovoked seizures, um, or they've had one seizure, one unprovoked seizure, but there's a high risk for additional seizures. So, what do I mean by seizure? I guess might be a good place to start. So, a seizure is really abnormal sudden abnormal electrical activity in the brain that can then lead to either movements or behaviors or loss of awareness, sort of unintended either behaviors or movements or speech on the part of the individual who has the seizures. What do I mean by unprovoked? Well, a provoked seizure would be something like head trauma, a fever, withdrawal from alcohol or drugs, a medication. Sometimes a side effect could potentially be a seizure, sometimes structural brain abnormalities. So the idea is that in order for somebody to be said to have epilepsy, they really have to have a pattern of unprovoked seizures, and they really ought to be at least more than 24 hours apart, or they potentially could be attributed to the same sort of underlying trigger.
Mhm. And one thing I think about when you say unprovoked, so part of that, I guess, is that we don't quite know the cause, right? Because if it's provoked, we know what's causing the seizure, but in unprovoked, we may not know what's causing that
Yeah.
seizure.
Yeah.
And so for epilepsy, in terms of having multiple seizures, is it something that ends up being inherited? Is that why we can't determine the cause initially? Eventually, is something found to have caused it that's not inherited?
So there are a few different sort of categories of causes, some of which I mentioned before, but sort of metabolic causes, structural causes, infectious diseases, for example, medication. And so when you're evaluating an individual for epilepsy and the sort of underlying etiology or cause, you want to try to rule out those kinds of things that are either easily identifiable or treatable, like a vitamin B6 deficiency, for example, which can turn out to be genetic in some instances. But so, there's many causes of epilepsy that have nothing to do with genetics or heritability. And then there's a group of individuals who in the past we might have said had unexplained epilepsy due to unknown cause. That there was sort of a whole kind of category within the International League Against Epilepsy's schemata in terms of thinking about cause. But what we've begun to learn more recently is that for some individuals with unexplained epilepsy, there are, in fact, sometimes underlying genetic causes, some of which are inherited, as in the case of an extensive family history of epilepsy, and in other instances might be happening for the first time, a new genetic alteration in an individual.
Okay, so in that respect, then it's genetic, but it could be something that was genetic from, let's say, a parent or genetic that shows up new in that person.
Yes. Yeah. That's something we've come to understand a lot more about over the last decade or so.
Okay. Because I think that's one of the things too is people think about, oh, I don't have a family history of it. So how did this happen to me? But that doesn't necessarily, just because you don't have a family history doesn't mean it's not genetic or that you might not need a genetic evaluation.
Yeah, no, exactly. And we have that conversation a lot in the clinic because, especially in my world, which is pediatrics, we often see either infants or young children who are being evaluated because of recent onset seizures. Maybe they have other accompanying features. Maybe they're a little bit older. There's a sense there's some developmental delay, for example. We do go over the family history in great detail, but Not infrequently, we hear there really isn't anybody with seizures, a history of even one seizure, let alone epilepsy in the family. But quite frequently, when we do the genetic evaluation, we identify what's called a de novo or new genetic variant in that child that probably wasn't inherited from either parent and just arose for the first time in the egg or the sperm cell.
What is the role of the genetics, in that diagnosis?
Yeah, I mean, I think that's one of the ways in which learning more about the genetics of epilepsy in particular, as opposed to some of the other childhood onset neurological disorders, has really moved quite rapidly into the sort of treatment and management realm. There's probably over 1,000 different genes at this point that we know potentially play a role in epilepsy or are kind of associated with different epilepsy syndromes. Of those, there might be a dozen or so where there's an immediate recommendation for either a treatment change or cessation of a particular medication that might exacerbate the seizures. So, most of the time, we're not talking about immediate changes in medication management, but we might be talking about things like an individual who has a genetic epilepsy syndrome identified where we know there's a higher likelihood for, say, cardiac malformation or renal malformation, or maybe the child needs to be followed for early onset diabetes, for example. So there's lots of ways in which making the diagnosis, even if there isn't an immediate, what we call precision treatment, might impact medical management in the short term. The other thing that really is helpful about it is that for many of these individuals, they've either been on a very lengthy diagnostic odyssey or they might be facing one otherwise. A child might be in line for, say, a lumbar puncture, a brain MRI, skin biopsy, a muscle biopsy. So if we can make a genetic diagnosis through either a blood test or a test using a cheek swab sample or a saliva sample, there are things that can be avoided, right? That, are painful and invasive. And then in some instances, if we make a diagnosis of something that's really quite life limiting, the family would then have earlier options to think about palliative care rather than sort of continuing to attempt to make a diagnosis and sort of trial and error with different medications at the end may really not prolong life and may not increase quality of life, whereas palliative care would at least increase quality of life.
And one thing I'm curious too is, because you mentioned what, I think 1,000 genes. So, clearly it's complicated, and you work in the pediatric setting, but are there genes or genetic causes for seizures later in life? Or does most of these genetic causes tend to present in childhood?
I mean, most of the ones that we know about are childhood onset, but honestly, I think that's just because that's where more of the research has been. That's where more of the focus has been. Certainly, payers are more likely to cover broad-based testing like genome sequencing or exome sequencing or even panel testing for children, where from the payer perspective, the argument is the test isn't worth doing unless it's going to impact medical management. We know a lot less about what the outcome or the impact of testing looks like in adults. But I can say that sort of some of the earliest epilepsy genes that were identified, so back in the mid to late 1990s, really were more adult onset seizures. And these were identified in families where there was a very extensive history following an autosomal dominant transmission inheritance pattern. So it's not that there aren't genetic epilepsies where seizures begin later in life. It's just that more of the focus has been on sort of the earlier onset pediatric epilepsies. But I expect that we will learn quite a bit more over the next few years. There's actually a recently formed task force through the American Epilepsy Society or AES that's going to be focusing really on adult epilepsies and the genetic underpinnings.
What are some other things that families would look out for if this is something they need to be concerned about? And then how do these folks find people like yourself to talk to about this?
Yeah, I mean, we are well positioned at at the hospital that I work at, to be able to offer uh, testing either clinically or through research protocols to a really wide range of children with different clinical histories, medical histories, different insurance payers, different ages. Historically, when really started focusing on epilepsy at children's, we were primarily meeting with families whose children were a bit older, 3, 4, 5, sometimes even significantly older than that, who'd already been kind of on a lengthy journey. And these were mostly children who, yes, they had epilepsy, often not well controlled, but frequently they had other, what we call comorbidities, right? Other accompanying medical or developmental or neurological issues. So spectrum disorder, cognitive issues, global developmental delay. And so they were kind of finding their way to us through our colleagues at Children's Hospital. But as centers like ours have kind of grown in size, and as word has kind of gotten out that this kind of testing is available and is recommended for any individual of any age, really, with unexplained epilepsy, we're starting to see a lot of families who are coming from out of state, from overseas, who are really looking for answers. Frequently, they are looking for treatment answers, right? Because it turns out that medication management for epilepsy is quite challenging. So, fully a third of individuals have what we call refractory epilepsy that doesn't really respond to a wide variety of different medications. So sometimes families are coming just because they've reached a level of desperation about how to control the seizures, right? But depending on how their child is doing otherwise, they might also be looking for answers to try to improve cognition, to try to improve gross motor skills, fine motor skills. They may be quite worried if their child has gone through some periods of regression, that their child maybe has a degenerative condition that might be life limiting. So I think what unifies all of them is kind of looking for answers as to why, why their child has seizures, why their child has other accompanying medical or developmental issues, what the future might look like. So, questions about prognosis, how they can best optimize services for their child, whether that's PT or OT or ABA therapy. And then ultimately, they are looking for a precision treatment, even if it's not available right now. They're looking for entry into research studies like clinical trials, for example, which at this point, it's not enough to have, say, a clinical diagnosis of epilepsy necessarily. It can sometimes be important to know what gene we're talking about, and even beyond the gene, what specific variant in the gene, in order to get into a trial that, may or may not be useful for their child, but might be something that would kind of help down the road. And then I guess the other thing I would say is that many, but not all of the families that I meet with find it really comforting to connect with some of the parent advocacy groups for lay information and support from other families. And we've really seen some great work in that space over the last decade or so.
Right, and for those resources, there are some, I would guess that maybe it's not just general epilepsy, right? Then there are some that are more focused on either this specific condition or this specific genetic change that was found, and so you're meeting other families with that exact same diagnosis, as it were.
Yeah, I mean, that has really just blossomed in the epilepsy space. So there are several hundred individual rare genetic epilepsy parent advocacy groups that are gene specific. And there's actually an umbrella organization called the Rare Epilepsy Network, or REN, that sort of brings all of these rare epilepsy groups together in partnership. They have some great resources on their website as well. But yes, increasingly, when a diagnosis is made, we can connect a family with an advocacy group that is specific to the diagnosis that their child has, rather than just kind of a general source of information, something like the Epilepsy Foundation, for example, which has a wonderful website as well. But if families are looking specifically to connect with parents or other individuals with the same genetic diagnosis, those parent advocacy groups have done incredible work over the last decade, since panel testing and genome-wide sequencing took off.
I want to sort of shift the lens a little bit. So we were talking about people that come in, some of them are looking for more information for a variety of reasons, like you said. And there are some that may be like, we're out of ideas. This is sort of a last resort. What happens when these folks come in and these families come in to you and nothing's found on genetic testing? Like, does that happen? And then what do you say to these families?
Yeah, I mean, that definitely happens about 50% of the time. I would say that's what happens. So certainly for the families who have older children who've kind of, come every couple of years and had the next, latest and greatest test, whatever that is, there's kind of that group. And then there's also increasingly neonates or really young infants who are presenting with refractory seizures, and they're kind of getting state of the art right from the beginning, right? So it's been really interesting to hear the reaction to what we call non-diagnostic, right, or negative results. We're just in the middle of publishing some data that relates to that in parents of young infants or neonates. And the negative results, what we've heard, first of all, we tell families a negative or non diagnostic doesn't mean there isn't something genetic there, right? It just means we may not be able to find it with the testing technology that we have at this point in time. And we know that, right? We've followed some of these children since 2011, 2012, 3 or 4 different genetic tests where we didn't find anything. And then all of a sudden in 2022, we make a diagnosis. So we know that to be true, and we can share that with families. And so we tell them how important it is to come back every year, check in with us, see if there's anything that's changed, anything new that we can offer them. We always recommend reanalysis of existing data, typically at the 2-year mark. For some individuals, depending on their specific kind of medical clinical presentation, we may in fact have other testing technologies that we might recommend to complement what they've already had. So we typically start with genome-wide sequencing, but sometimes just based on the history, if the genome sequencing is negative, we might go back and add something else to our testing arsenal that is, we wouldn't have started with that because that test maybe has a much lower detection rate. And it's not a great place to start, but it could end up leading to a diagnosis if used after we've kind of exhausted the most, kind of frequent genetic findings. But just getting back to the parental response, because I think this has been really interesting. By and large, what we hear from families when the results are negative is relief. Regardless of how their child is doing, they often tell us they feel relieved that there isn't something genetic, because there's kind of a perception that genetic is unchangeable, right? Or that genetic means more significant symptoms or a poor outcome. But those same families also tell us that while they feel relieved, they also kind of feel in limbo a little bit, as in, okay, well, you've ruled out everything you possibly could, and we've done this test. So now what, right? They don't have
Right.
answers. So that can be a frustrating place to be.
Yeah, I imagine too, especially if there's somebody that was it's both. It's sort of like we would want additional answers, but this may be not the answer that we're hoping for, right? And so it sounds like you recommend these patients though still stay in touch with their clinic and check back in, because you were talking about, there's new technologies, new ways of even looking at a sample that we got a few years ago. So how often do you recommend these families either come back or check in? How does that work?
Yeah, I mean, there's even new gene discoveries that are ongoing, right? So we've had situations where we did a genome test for a family 1 year, and then 6 months later, a publication comes out describing a novel gene. And, sometimes we might go back to the family right away and say, hey, this really sounds like potentially it could be an answer for your child. Let's do a reanalysis, right? So if there's new kind of what we call phenotypic information, right? If there's a new symptom that develops, new piece of information that comes from the literature, or if the individual's kind of overall medical status changes, that's a time to go back and take a look again at what's been done, and in particular think about reanalysis of the data that we already have if it's been within a year or two. If it's been longer than that, we typically do recommend getting new samples just because, things improve on the laboratory side. And then there's all kinds of new technologies like long read sequencing and RNA sequencing and DNA methylation testing. So these are not commonly used as first tier tests. They are sort of adjuncts or complementary to our bread and butter genome or exome sequencing. But we do increasingly utilize them in certain cases when we're really suspicious about something.
And that makes sense, and I it is incredible to think about myself being in this career for 20 years, where we started and where we're
Yeah.
at now, like, talking about long read and
Yeah.
methylation types of things, and, I mean, not to even just mention whole genome and whole exome, which was, not even a thing, so it is
Yeah.
crazy how genetic testing technology has progressed and the things that we can find now that we wouldn't have even been able to figure out 10 years ago.
Yeah, I mean, I finished my graduate training in 1994. So this is before the Human Genome Project was completed. And when I started clinical practice in prenatal, I think there were maybe 50 different single gene genetic tests, plus minus karyotyping, um, and Fragile X testing, but not molecular Fragile X testing. Yeah, it has been, I mean, I really entered into the world of epilepsy in 2010, so about 15 years into my career. And even that, just the changes that have taken place since I started in this particular area, um, have been quite dramatic, just an exponential increase in what we know and the tools that we have available to us.
And think about that, like the past and kind of where we're at now. What do you see as the future of like the epilepsy research or these epilepsy and increasing genetic knowledge about epilepsy?
Yeah, that's always such a hard question to answer, but I mean, I think certainly some of the tools that we've already just started to utilize, like long read, like methylation testing. I'm sure there's probably more to be identified in the world of expansion repeat disorders potentially. I should mention those 1,000 or so epilepsy genes, a lot of them have overlap. So they're not exclusively epilepsy genes. They have overlap with learning disabilities, developmental delay, autism, intellectual disability, movement disorders, brain malformations, kind of anything that you can think of in the pediatric neurospace. But um, one thing that we are actively using now, which is relatively new, and I think just an example of kind of what you're talking about, new directions. We're starting to look at deep sequencing of brain tissue from children who have cortical brain malformations. So this is kind of scenarios where the child is being considered for surgery, and so there's going to be an opportunity to get brain tissue anyway. And often these are individuals who've had germline testing. So they've had genome sequencing from a blood sample or a cheek swab, what have you, but there's suspicion that maybe the genetic alteration is really limited focally to the brain. And we've had that work is also in publication at the moment, but we've been able to identify again about 50 to 60% yield for those individuals with a deep sequencing panel test.
Let me make sure I understand. So these would be folks that maybe if we did like a blood test, we may not see the change or mutation, but if we were able to actually get the brain tissue, we see it there because that's the tissue that has this change or is showing this change. Okay. Yeah, that's fascinating. Okay, we'll have to stay tuned for more of that information. One thing too that I wanted to ask about because it's one that I hear often, and I'm not in neurology. Not, I don't even think this was an option for me to even study or get a rotation in when I was in graduate school. With epilepsy, is there a chance that people can outgrow it, or that they would stop having seizures? And is that one of the concerns, I guess, for folks that are like, maybe I don't want to have a positive genetic test result because I hope that they outgrow it.
Yeah, so meaning that the feeling would be if they had a genetic test and they learned it was genetic, that
Would
then
they worry that they're not going to
yeah.
outgrow it?
Yeah, I mean, I do think I mean, I work in pediatrics, so I'm talking mostly about parents here.
Mhm.
I can't speak as much to the adult side of things, but, I do often hear from parents, they are concerned if it's genetic that there will be a poor outcome or less likelihood that the seizures will resolve or that they'll be able to discontinue medications at some point. And honestly, it really depends on the specific gene that we're talking about and even sometimes the specific gene variant. But we certainly, I mean, there are examples of kind of what we call benign genetic epilepsies, where benign might be a little bit of a misnomer, but meaning that if you get one of these particular genetic diagnoses in a young child, the data are there that the seizures will resolve at relatively early in life, and the children should be able to go off their medications. It's obviously always going to be an individual call and something that the neurologist or epileptologist makes the determination about, but at least we do have that data about some of these genes, like there's a gene called PRRT2, and usually the children do outgrow or stop having seizures at a pretty young age, which is kind of good news if you're thinking about a parent of a young infant who's having seizures or seizure-like episodes.
Interesting. In terms of like epilepsy genetics, is there anything that you wish like the general public understood better, or is there maybe a common question that folks ask you about it, that you think would be helpful for people to be aware of here?
Yeah, I wish in terms of just epilepsy and not the genetic piece, there's a really long history of stigma against people with epilepsy. There was this, thousands and thousands of years ago, this idea that epilepsy was caused by evil spirits or demonic possession. And so, even in this country, up until 1970s or so, there was legislation around sterilization practices, and in many parts of the world, people are really still actively discriminated against. I think there's some sense that it might be contagious or communicable. And I just wish that people understood, um, that it's a health condition like any other. It happens to impact the brain. It happens to impact the brain in ways that may lead to, kind of sudden or unexpected body movements or behaviors, but it's just like any other medical condition that someone might have that may not be as obvious to people who don't know the individual. So I guess I just wish there were more of an understanding of that and more compassion, for because it's really that's a lot of what we hear from young adults and adults is just the stigma, and there's a fair amount of mental health conditions that may co-occur in part, I think, just because the experience of living with epilepsy.
Well, and I guess too, that's why it's helpful to meet some of these other folks and other families too, is to kind of be able to have people that understand because folks in the general public, some may be understanding, but it sounds like there's still a lot of misconceptions and assumptions,
Mhm.
incorrect assumptions that people are making. If you had a family right now, like a parent that was listening because their child was recently diagnosed with epilepsy, what is, or somebody that recently found out they have a genetic diagnosis that is contributing to the epilepsy. What is it that you think is important for them to hear first? Because I imagine it's a lot of information coming at you, but what is something that you would want them to take away, to remember?
Yeah, I mean, I think, especially in the context of a new genetic diagnosis, what I've heard over and over again from families is that the most important thing for them to hear first is how is my child going to do? What what can you tell me about prognosis? What can you tell me about treatment and management? That's what they want to hear about first. They really care a lot less, at least initially, many families, about the gene name and the biology of the variant. And many of them often don't even want to hear right away about the parent advocacy group and the sort of resources because they're inhabiting this space. I mean, really just like any other pediatric genetic diagnosis of, the dissonance between what they expected and what their child is experiencing. And so giving them a sense of what to expect, but I think in particular framed as a range, right? For many of these genetic epilepsies, there may only be 20 individuals described in the literature or 50. We're not talking about really, really common conditions, right? So genetic epilepsies together are fairly common, but they're each individually rare. So returning a result back to a family and not framing the context of the information in such a way that they appreciate, this is what we know about the 5 individuals who've been described in the literature. That does not mean that this
Right.
is what the future looks like for your child, right? And here are the suggestions we're going to make to optimize what potentially could be challenges for your child, right? But I think it's so important to frame it that way, to give people hope and to give them kind of a way forward at a time when they've kind of fallen off of a cliff. And it's a very foggy and terrifying moment because most people don't have a lot of familiarity with genetics. So I think really focusing on those things first and coming to all of the science and the biology later, if when somebody really wants that. I think if we're just talking about new onset epilepsy, let's say in an infant, and we haven't even gotten to the genetic diagnosis yet, that's also terrifying, obviously. Most people, parents experiencing that, have not seen a seizure before. They don't know what it is. They don't know what it means. They just want it to stop. And, I think getting to a center that's skilled in how to treat seizures, and how to support families in those early days is so important because I've heard lots of stories of, families who've gone to either an ER or a local hospital, and it's taken quite some time, to get to a level 4 epilepsy center or a NICU that knows how to handle those kinds of situations and be able to, again, provide the support, especially for new parents, right? First time parents who don't have anything really to compare.
Right, and I think that's so insightful is that this is, like you said, it's like falling off a cliff. It's very can be very scary, and I think, like, any parent's priority is, what does this mean for my kid and my child? But then I also think you bring up something very important for the healthcare professional, is that this is their child, and we wouldn't necessarily say this is exactly what's going to happen and what we predict for any kid. We can say, here's what we expect, anticipate, but like you said, it's a range. And I think that's so important to be able to communicate that to families, that this isn't a definitive end all be all type of answer.
Yeah, I mean, exactly. I find just letting people know a little bit. I mean, hopefully this happens on the pretest side, but a little bit about the history of It's what's happened over the last 10 to 15 years, right? And why we know or don't know the things that we know or don't know. But I would add to, what I said before as well about, predictions and the predictive value of genetic information, because it's the gene, but it can also be the individual variant, right? Is this a variant that's been described in any individual before? Because sometimes, I mean, you know this, right? You can have a variant in one part of the gene that has a markedly different impact from a variant in another part of the gene, right? So different parts of the protein that's produced, or a different impact in terms of, the protein being truncated and decaying versus a protein being sort of upregulated or downregulated. And even within some families that all have the same genetic variant, you can see markedly different phenotypes or clinical presentations. So, if within a family with a variant in, say, the SCN1A gene, which is a sodium channel gene, you might have several individuals who had a febrile seizure in infancy. That was it. You might have individuals with seizures that continued past early childhood, but ended up resolving, or people continuing to have seizures later in life that are treated with medication. And then there might be an infant born with a much more a significant clinical picture consistent with what we call Dravet syndrome, which involves more than just seizures. It also includes, cognitive issues and developmental delays, and a whole host of other comorbidities. It is really, really important that as a parent or as an individual pursuing genetic testing, that happen within the context of healthcare providers who really know how to interpret the findings for that individual.
Well, and that's what I was gonna say is I think that just again speaks to folks getting plugged into experts like yourself, and then like you mentioned, this kind of care team that resides, unfortunately, not at every hospital,
Yeah,
but that they have to kind of find. But we'll put some resources too in the show notes for folks to be able to find like genetic counselors and some of these clinics as well.
yeah, that sounds great.
And Beth, I just want to thank you so much for being on the show today and sharing your insight and expertise. This was really, for me, a fascinating discussion because I learned a ton, which I had not known before about epilepsy and genetics.
Thank you so much for having me.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all the episodes of the show. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Please rate and review the podcast on Apple, Spotify, YouTube, or wherever you listen. This helps other people like you discover the show. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. All Access DNA is an independent podcast hosted and produced by me, Kate Wilson. Designs by NKJ created the logo. Thanks for listening and join us next time.